Hello, everyone. Thank you for joining us today. I would like to welcome you all to the International Journal of Clinical Research. IJCR is an organization rooted with an aim to facilitate and promote high quality research, publication, and interactive clinical content for physicians, educators, and the global medical community. Part of this initiative is the Future Leaders in Medicine webinar series. My name is Peter Samuel. I will be your host for today. I'm a final year medical student from Tbilisi, Georgia. I'm currently a member of the Medical Student Advisory Board and the host for the podcast Medicine Beyond the Science. Before we invite the speaker for the evening, we would like to give a very short introduction to the journal. I now invite Dr. Keval Thakur, the Assistant Director of the Pioneers in Medicine webinar chapter, to introduce the journal.
Thank you, Peter. Hello, good morning and good evening, everyone. My name is Keval Thakkar, and being the member of the organizing committee of this event, I'm really honored to be presenting the International Journal of Clinical Research today. So what exactly is IJCR? IJCR is registered as a non-profit organization in Delaware, USA, where it has zero article processing charges. It is an open access journal, which has peer review articles, and we provide interactive clinical content to the global medical community. The aim of this journal is to establish an equal platform for all researchers, as well as encourage and promote the scientific research community to do better and better. Within its scope, it publishes case reports, case series, narrative reviews, and also original articles. Due to its system and quality of its article, IJCR has obtained indexation from ISSN, Google Scholar, Crossref, DOI, Publons, and it's also in the process of getting an indexation from DOAJ, PubMed, and Scopus. Despite IJCR being so young, it started in May 2020 with 5 countries and 9 cities. However, today it has achieved an exponential growth by reaching 145 countries and around 2,300 cities. This data has been presented by the Google Scholar Analytics. This was also achieved by having mentors throughout the editorial process, and we are proud to say that we have started the board of advisors, and one of them is the mentor of Dr. Nicholas Gregory, Professor Dr. Edmund Barakat, who also happens to be the Dean of Undergraduate Studies at the University of Sao Paulo. He has played a vital role in providing a path to the starting of this journal. We also have an organizing committee with our CEO, Dr. Gregory Nicholas. We have managing editors, assistant managing editors, a production editor, and we have advisor journal editors as well. The editorial board consists of multiple editors from different fields of different specialties. They focus on obtaining great quality publication, as well as guiding our authors with a unique system that provides guidance without letting them lost in the difficult world of publications. We also have a section for guest editors, and we also have a couple of new editors who have recently joined our journal. Our journal has so far been successful in publishing 3 volumes with a variety of articles, including original articles, case reports, and narrative reviews. These articles are published after undergoing a vigorous peer review system organized by our editors. Please do visit our website to check more about these articles. IJCR is divided into webinar series, which has a Pioneers in Medicine, and the current one, which is Future Leaders. We also have the podcast Medicine Beyond the Science. We have an applied research skill course, and one of our biggest division is the Medical Students Advisory Board. Starting with the webinars Pioneers in Medicine, its main focus is to inspire young minds by showing them the accomplishment and research of great experienced researchers and how they have impacted the world. This is directed by Dr. Hiba Sati, and I'm very proud to be a member of the lovely organizing committee along with my colleagues. We also have the Future Leaders in Medicine, which features early career medical profession researchers with great innovative achievements to discuss their work and share a piece of advice to our young researchers. We started in April 2021 with Dr. Bruce Chesson, who is also famous for the Chesson's criteria for Lymphoma Foundation. Then we hosted Dr. Kentish's, Dr. Gale, We also hosted Dr. Patrick Hu, who happens to be the president and CEO of Moffitt Cancer Center. Then we had Dr. Rothenberg, who is the former chief medical officer of Pfizer. We had Anthony Chang, who is also known as the father of AI. And then we also had recently Dr. Salim Abdulrauf, who is the founding chairman of the Department of Neurosurgery at St. Louis University. Our future leaders in medicine started with Dr. Grayson Armstrong, the director of ophthalmic emergency services at Harvard. And then we also hosted Dr. Mari Mitrani, the chief science officer and co-founder of the Organ Cell Regenerative Medicine. We have our podcast, Medicine Beyond the Science, hosted by Dr. Peter Samuel, who has a passion for stories for medical professionals, researchers, and special guests to highlight their unique stories, personal experiences, and contributions to medicine. We already have several episodes on all podcast channels, so tune in and make sure to listen to the great stories behind each person. And one of our biggest divisions is the Medical Students Advisory Board, where we have more than 150 medical students and fresh graduates from 40 different countries. This Students Advisory Board would not be at a place where it is current right now without having the mentorship of our advisor, Dr. Nancy Emanuel, our presidents, our vice presidents, and then we have our executive assistants and the chief administrative officers, and we also have the admission officers who make sure we have all the administrative process in line. We also have our research officers who have been mentoring our students and piling them up into research working groups where we have ongoing more than 34 research articles currently. I mean, already published a couple of articles. As you can see, these students come from a very diverse background. We have people from Brazil, Lebanon, Peru, China, India, and a lot more. The MSAP division is divided into following 9 chapters. It has a journal club chapter where we discuss articles and kind of do a critical analysis of how the articles have been published. We also have a digital health chapter where we discuss all the recent latest trends in terms of digital and AI in our medical community. We have a USMLE study group, and we also have a growth and development chapter. Thank you so much for your attention. I'll leave you now with Peter.
Thank you very much, Keval. As the term international would imply, we have a team of representatives from all around the globe. Through the Future Leaders in Medicine webinar series, we work hard to bring to you some of the most eminent professionals who not only pioneer healthcare, but also shape the very course of it. As the third speaker as part of this series, we have Dr. Syed Azoury, a very prominent plastic surgeon from the United States that's joining us today. Thank you very much for joining us this evening. I now invite Ms. Hebasati, the director of the Pioneers in Medicine webinar chapter, to introduce the speaker for the evening.
Thank you so much, Peter. In IJCR, we believe in the free and equitable distribution of knowledge. We also firmly believe that the youth is our future and is directly intertwined with research innovations. Therefore, we launched the webinar series, an initiative where we bring to you medicine's most prominent luminaries discussing their medical journey, research discoveries, and passions in hope that it will inspire you. None of this would have been possible without our dedicated team, and I'm fortunate to have a passionate, hardworking, and remarkable team to make this event a reality. Today, I'm thrilled to introduce to you one of the leading figures in plastic surgery, Dr. Saeed Azoury. Dr. Azoury is a double board certified plastic surgeon affiliated with the University of Pennsylvania School of Medicine. His training spans general surgery at Johns Hopkins, surgical oncology at the National Cancer Institute, and plastic surgery at the University of Pennsylvania. Additionally, he completed a fellowship in surgical oncology and reconstructive microsurgery at Memorial Sloan Kettering. With clinical expertise in head-to-toe reconstruction, focusing on lymphedema, lower extremity salvage, and breast reconstruction, Dr. Azoury has authored over 13 book chapters and 80 journal publications, particularly in oncologic and traumatic reconstruction. In an effort to regionalize severe lower extremity damage and improve limb salvage outcomes, he is credited with creating the lower extremity guidelines for salvage. He describes that the best part of his job as a plastic surgeon is patient care, as well as his ability to be creative and innovative in the variable surgeries he performs. While I could delve further into Dr. Saeed Azoury's merits and achievements, I believe you'd prefer to hear it directly from the man himself. Without further delay, I present to you the man of the hour, Dr. Saeed Azoury. The floor is yours.
Thank you so much, everyone, and thank you for joining me. Can you hear me okay? Okay, great. Let me share my screen. It may, let me see if it's allowing me to share it. Give me 1 second. Okay, it's not letting me, but give me 1 second. If this doesn't allow me to share it, then maybe I'll just have you show the screen and we'll go from there.
Can you see my screen?
I can, yes. But this won't allow me to advance it. Is that correct?
No, I'd be advancing it from here. You can let me know once you want me to skip for the next one.
Okay, can you give me one? I'd like to try to share it from mine. Can you give me just 1 more minute? Sorry, and I'll
Yes.
stay on time. Give me one.
No worries, take your time.
In this time, I would also like you all to know that there will be a feedback form that will be circulated towards the end of the talk. Please do fill it in and submit it in order to secure a certificate. And in a couple more minutes, I think we can continue. We're just trying to figure out if the speaker can share his presentation. Thank you.
In the interest of time, we can proceed, and I'll just tell you to advance the slides. Sorry, there are some videos that are embedded on my side of the screen, but that's okay. The overall
Can you
picture
try
will.
again? We assigned you as a co-host now again once you joined.
Okay, let me see. Okay, give me 1 second. This might work. Yes, hold on. Okay, I think this works.
Yep, we can see your screen.
Excellent. Perfect. Thank you so much for your patience. Everyone can hear me okay?
Yes, we
Okay,
can.
excellent. Excellent. So thank you so much. I think it was worth troubleshooting this just so that I can show some stuff from my. I feel like one of those really old people, even though I'm not that old, trying to give a presentation, where it takes like 15 minutes to try to set it up. So thank you so much. It's an honor to talk to all of you today. And if you have any questions or want to stay in touch after this, feel free to connect with me. I am on social media, and I'd be happy to mentor any of you from far. But my name is Saeed Azoury. I wanted to give a talk today that hopefully some of you can relate to, and just to share my personal journey, but also to help inspire you guys in your future, whatever your career you may choose. The topic of my talk is a pathway to academic plastic surgery, personalizing your practice. And even though I had a sense of what I wanted to do with my life, even just growing up, based off of things that I'll show you, things that I went through in life kind of helped pave the path for what I'm doing right now, which you'll see. So some of you know, but I was born in Beirut, Lebanon, and I know that this is an international audience. So I'm very proud of my country, and I think that that's a very, very important thing as you to always think of your roots and where you come from, and to help those that come from where you were. And I'm always interested in helping people, especially from my country, advance in their career. And it's a beautiful country, and so hopefully you all have the chance to visit. But my path to medicine really started with watching my dad as I was younger, and this is him. He was chair of obstetrics and gynecology at the American University of Beirut. He actually came to Baltimore, Maryland to do his residency training at Hopkins, even though he had already completed his residency training at the American University of Beirut. And it kind of shows you what international graduates sometimes have to do. They have to go the extra step. So even after completing full training overseas, he still had to come to the United States to complete additional training. But what I like to share with most people is that I personally think that the training abroad is excellent. In many ways, it's even better. And so when you do your own training abroad and you come to the United States, you shine even more. And that's something he was able to do. And so he went to Hopkins after he did his residency training in Lebanon, and he was accepted as a preliminary resident, which basically means you're there for a year with no guarantee that you're going to stay on. But as I mentioned to you, I think that those international students and rotators have a certain work ethic and work really, really hard, and oftentimes come from very rigorous backgrounds of education and training. So he was able to shine, and obviously they kept him on. And here he is as a chief resident, as one of the two selected administrative chiefs for his department, at one of the most historic and world-renowned programs in the world. So hopefully that serves as a little bit of an inspiration to you all coming from abroad. This is me and him, and we were obviously very close growing up. Unfortunately, life has its ups and downs, and it certainly went pretty far down when he was diagnosed with a rare type of cancer, bile duct cancer, when I think I was, around 7 or so. And luckily, due to his training at Hopkins, he knew a guy named John Cameron. And John Cameron is a world-renowned pancreatic biliary surgeon. And really advanced the career of surgical oncology, particularly Whipple surgery for patients with pancreatic and bile duct cancer. So because he did his training at Hopkins and he knew John Cameron was able to offer him a very rare operation that he was really not doing that frequently. And this was around the time that people were giving my dad about a year of prognosis, basically saying that in a year he was going to pass away. And at the time he was 83 and I was probably around, at the time he was 63 and I was about 7 years old. So obviously it would be a hard rest of my life if I lost my dad at the age of 7. Luckily, Dr. Cameron offered him a Whipple operation where he basically rerouted his internal organs, took out the cancer that other doctors were saying were going to cause him to die within a year, and even not offer him surgery. And fortunately, I had many more years with him. And in fact, this is a picture, I think, probably of us smoking a cigar maybe 15 or 20 years after his original diagnosis, when people said he only had a year left to live. He clearly inspired me to become a physician, and he was obstetrics and gynecology. He operated a good bit, and I realized I wanted to do surgery. And so he was an attending physician at Eastern Virginia Medical School in Norfolk, Virginia. This medical school actually had a lot of people from my hometown of Lebanon, and my home country of Lebanon, and still does. But it also has some connections with Hopkins. So in the upper left-hand corner are Howard and Georgiana Jones, and they were good friends of ours when we were growing up, but they were also the people who pioneered in vitro fertilization. So she came up with the pregnancy test or everything behind the pregnancy test that we all know today. And together they both came up with in vitro fertilization. And because my dad was a faculty at this medical school, I wanted to go there, and it was in my hometown of Norfolk, Virginia. So I went to medical school there, but as a fourth year, it's a very small medical school. But with everything that my dad went through, he studied at Hopkins. He got surgery at Hopkins when everyone was telling him that he was going to die and there's nothing to offer. I said, okay, I come from a very small medical school, but I really want to give it a shot to maybe go to Hopkins for surgery. And many people laughed and said, you come from a very small medical school, they would never look at you. But I said, let me just go there for a month, and I'm going to work the hardest that I've ever worked before in my life. I would wake up this is a picture of my room at the time. I was just so excited to be there that I was taking pictures of everything. And I would wake up at 3 a.m. and shave every day. And I was the last person in the hospital. I probably worked from 3 a.m. to about 10 p.m. every night. And I was absolutely exhausted. Some days I remember being in the operating room and as a medical student and standing up and kind of falling asleep as I was standing. I don't recommend doing that, but it just shows you when you're afforded the opportunity to work, to shine, you really have to work really, really hard. And actually, some of these shirts in my closet I still have. But so while at Hopkins, I was kind of mesmerized by everything around me, just as a medical student from Norfolk, Virginia. This is Alfred Blaylock. This is Harvey Cushing, the father of neurosurgery. This is Halstead, the father of surgery. This is Vivian Thomas, who was working in Alfred Blaylock's lab and came up with the Vivian Taussig shunt. And of course, most importantly, this is a picture that I saw when I got there of John Cameron, who was the guy who saved my dad's life. And when I saw this picture, and you can see kind of my reflection in the background of taking the picture, like I said, I was kind of taking a picture of everything. This really struck home and really told me, yeah, I can do this. I come from a small medical school. This Hopkins usually takes people from Harvard, Yale, all these other Ivy League schools. But if I work hard and show my passion, I can make it. And luckily on match day at my medical school, here's me on my left side, still kind of in disbelief, getting a letter saying that I was accepted for general surgery at Hopkins. And this is me with my dad, 20 years after his original diagnosis at my graduation of medical school. So I went from a very small medical school that no one ever heard of to probably the most respected and world-renowned general surgery training program in the world, and I couldn't believe it. And it was really a dream. I think uh, here's me pictured with all of my colleagues in the left-hand photo. I met my wife there. She was an ICU nurse, and we kind of lived in the hospital at the time. So obviously, we all found our significant others by other people who were working in the hospital because we never left the hospital. And this is me at the top of the helicopter pad on the right-hand side. This is really like these pictures kind of show you how I felt. It was really a dream, and many days I would wake up and I couldn't believe it, to be honest with you. And what's sort of interesting, and hopefully this hits home as much as it kind of, the hairs on my arms are sticking up right now, just even looking at this picture. But if you look on the right-hand side with all these people around him, this little guy right here is John Cameron. So my very first operation I did was the guy who saved my dad's life. And he would always have about 10 to 14 people around him observing him because again, most people consider him to be the most famous general surgeon probably in the history of surgery. And then this is me kind of frantically trying to tie in front of all these people, which was, I'll never forget how nervous I was. My hands were shaking so badly. And he told me, it's okay, you're doing a great job, but I can't say how nervous I was. And this is kind of the picture where I felt like I was on top of the world. But just like life has its ups and downs, whenever you feel like you're on top of the world, you kind of have to, thank God for everything, because life can turn around any moment. And it certainly did. But I was actually going to be the person to help Dr. Cameron with his 2000th Whipple. And this was a day when, the news broadcasters were coming. Everyone was going to come and interview me, interview him. They're going to film us in the operating room, etc. And you can see all of these like celebratory things. And unfortunately, I got a call saying that my dad had fallen and hit his head, and he was diagnosed with a new type of cancer, which is stomach cancer, and it was pretty advanced, and it actually came back metastatic. So in that brief time where I felt like I was on top of the world, the whole reason why I went into medicine and surgery, was kind of dying before my eyes, which was my dad. And he unfortunately ended up passing away when I was a second year resident. And, this is how I felt. I felt that cancer sucks. And what does anyone do who feels that cancer sucks? They try to treat it, and they try to give back. And so in the middle of my general surgery residency, I was accepted into a surgical oncology fellowship at the NIH, which was a 2-year program. And it was really to help work with people who had cancer. Again, I was just, in a way, it was a little bit of a mental break from general surgery residency, but it was also, every day a reminder of my dad and trying to give back to people who had cancer. But fortunately, even though I wasn't able to make the Dr. Cameron's 2000th Whipple, I was able to scrub on his very last case that he ever performed in 2016. And every day I scrubbed with him after my dad passed away. It was a reminder of what he did for my dad and giving him an extra 20 years of life. And my dad ended up passing away at the age of 82 when he was originally diagnosed at 63. So pretty remarkable. But this was me and as a chief resident at Hopkins, and I kind of shifted a little bit of focus from oncology to also lower extremity reconstruction. We did a lot of vascular surgery, and a lot of what we did was limb salvage for patients who had pretty severe lower extremity ischemia and diabetes, et cetera. And so this is me in the middle as a resident doing a limb salvage procedure. And then I went from Hopkins to Penn. And part of the reason why I went to Penn is because Penn was really well known for its cancer reconstruction. at the University of Pennsylvania, and also lower extremity salvage, which was a personal interest of mine. I was actually reminded of this story when it comes to lower extremity reconstruction, which is kind of what developed my interest in lower extremity reconstruction. But this is a story of Cosmas and Damien, who came across, their two saints came across a guy with a very basically ill leg, and you can see he had a necrotic leg, and so they went to a nearby morgue, and they transferred or transplanted a black leg from an Ethiopian who was buried, and transplanted it on this guy who had a very sick and necrotic leg. And the miracle has it that the guy was able to walk immediately afterwards. But this dates all the way back to the 3rd century. But it kind of reminded me of all the cases that I saw at the University of Pennsylvania with these lower extremity wounds and injuries. And I really developed an interest in the lower extremity. But I also wanted to take care of the cancer patient. And like I said, there are little things in life for all of you that remind you why you want to do medicine, or why you want to do what you do. And a lot of it for me is seeing what my dad went through, and wanting to help others in that situation. And so, because I also had an interest in the cancer patient, I wanted to go to Memorial Sloan Kettering Cancer Center, where they did a significant amount of reconstruction, but also all of my care would be devoted to the cancer patient. So I spent a year there. This is us here. And this is all of our group here. And then this is me in the middle. This is me and my wife, who I met at Hopkins originally. And really the various pathologies that we saw were all related to the care of the cancer patient. And to me, taking care of patients who had, when I initially did general surgery residency, it was to be like John Cameron and to take care of people like my dad, who had bile duct or pancreatic cancer. But I found that to become too depressing when I saw that my dad was really struggling with metastatic disease and ended up dying. And it was too depressing for me to live with that on a daily basis. So I decided, well, I can't treat the same patient as my dad, but I can reconstruct cancer patients. I found that to be a little bit more fun and exciting and happy, rather than being depressed every day by having the thought of my dad struggling with cancer. So I still wanted to take care of the cancer patient, but in a different way. I wanted to reconstruct defects. And that really was available in the field of plastic surgery. And my dream came true after that. And I was able to go back to the University of Pennsylvania. And you can see here in the beautiful city of Philadelphia, I welcome any of you guys to visit. It's such a special institution. And I went back as a assistant professor of plastic surgery, orthopedic surgery, and I also am the associate program director for the plastic surgery program. But when I went back, I thought to myself, how could I really incorporate the most enjoyable aspects of my training into my future career? And for each of you, regardless of what you want to do, you always have to think, how can you take everything that you learned about as a trainee to really make the practice that you'd want for the rest of your life? And for me, that was really two things. I wanted to take care of the lower extremity, and I also wanted to take care of patients with cancer, again, because of my dad, and help reconstruct some of their wounds. So with regards to the lower extremity, I was really interested in the fact that a lot of patients get treated at smaller outside hospitals for lower extremity injuries that end up leading to amputation. But these patients ultimately have a delay in their care, whereas if they were seen at a higher volume tertiary academic medical center, their care is expedited, they're seen by experts, and frankly, simply put, the care is just better. And I always used to think to myself, it's unfortunate all these people who get amputated at all these outside smaller hospitals, who probably, if they went to a bigger institution, they would be able to keep their legs. And this is a quote from Marco Godina, who's a plastic surgeon who is also very interested in lower extremity reconstruction. And he said, delay is excusable only when you're debriding essentially a leg that has necrosis, or in the case of inadequate knowledge, skill, or facilities. And that last part is important, in case of inadequate knowledge, skill, or facilities. So I thought to myself, if these outside hospitals where patients are getting amputated have inadequate knowledge, skill, or facilities, there should be a method to transfer those patients quickly to places that have adequate knowledge, skill, and facilities. And one of my mentors on specialized care says it is better to delay coverage or even transfer a patient to another center than to have an inexperienced team of personnel try to provide coverage with an unsuccessful outcome. So just as a quick background to lower extremity reconstruction, there are about 180,000 lower extremity amputations performed annually. 45% are trauma related, and there are 700,000 Americans living with traumatic lower extremity loss. And that's estimated to be 3.6 million by 2050. But I didn't want this. And, I don't like the fact that people get lesser care at other hospitals just because those hospitals are smaller. That just happens to be next to where the patient lived or next to where the car accident was. And I felt that these patients should really be provided with equal access to saving their leg. And one thing that I was interested in, just with my general surgery background, like if you compare these numbers to burn injuries, there are only 50,000 patients hospitalized annually for burn injuries, and 20,000 are considered severe. Whereas above, there's 180,000 lower extremity amputations, and 704 are living with traumatic loss. But despite that, we have transfer criteria for burn patients. So if a patient comes and has a big burn, those patients are at a community hospital that has inadequate knowledge or inadequate facilities, those patients can be transferred to a more specialized center based off of these criteria. But there is no such thing for lower extremity injuries. And so at the time I thought, well, let's create the lower extremity guide for salvage. And this guide will help community centers treat these patients and facilitate transfer to other centers as quickly as possible, so that hopefully we can save more legs. And the way that it sort of works is, this is in the upper left-hand corner. This is the community center where they're calling the lower right-hand corner, which is a more advanced institution that has the capabilities for saving legs. And the community center is calling and saying, I have legs for trauma transfer. And then the more advanced institution says, we are happy to accept. And basically the patient and so from there, even though we had this whole thought process of how can we create the lower extremity guide for salvage, we kind of had to prove proof of concept and why we needed it. So we looked at our own experience, and we looked at the flap reconstruction for lower extremity trauma from 2002 to 2019, 178 patients, and the time to soft tissue coverage was longer in patients who were transferred to our hospital. The rate of osteomyelitis, which is a severe bone infection, was higher in transfers. Limb salvage rates were pretty similar for those who were directly admitted to the hospital versus those who were transferred. And we were still able to achieve a full weight-bearing status in the majority of patients. Then we did a systematic review and meta-analysis of patients who are, directly admitted to a tertiary center, so a pretty advanced institution, versus those who end up getting transferred. And if following a trauma, you're able to be directly admitted right away to an advanced medical center, then that will decrease your number of surgeries, your wound infections, systemic infections, total complications, risk for diabetes, and venous thrombosis. Whereas those who unfortunately get seen at a community center and then are transferred have a higher rate of all of those risks. And then one thing that I was interested in was orthoplastic care. And orthoplastic care is really advanced care of the lower extremity injury. And if you're at a center that's able to offer this care, then the care decreases time to bony fixation, use of wound vac, and risk of infection. And we were able to publish that study as well. And then we looked at our own center, because we were an advanced center that does a lot of lower extremity injuries. And we were able to see that prior studies showed that non-white race and disadvantaged socioeconomic status negatively impacted outcomes, and that African Americans were more likely to suffer lower extremity amputation. But what we wanted to see is we wanted to evaluate our own institution. And because we're an advanced center with all the kind of everything in process and in place to deal with these patients, we were able to treat, disadvantaged groups or people from diverse backgrounds with no difference in outcomes than those who were more privileged. So, in summary, we came up with the lower extremity guideline for salvage, and this is a guide that is used by, it has been published in all of these journals on the left, and really helps community centers. Hopefully that's the goal for the future, to know when is it necessary to get in touch with a more advanced center to help transfer these patients so that they could have an opportunity for saving their leg, rather than just amputating the leg because they don't know any better. And that's why I created the lower extremity guide for salvage. And we have a pretty significant orthoplastic group at the University of Pennsylvania. But more important than that, I went back to my dad and cancer. And so even though I was doing that thing on the lower extremity side, I thought to myself, well, I still want to take care of the cancer patient. And this is where each and every one of you who's listening to this call, regardless of what you go into, just know that you can personalize your own practice and you can do whatever you want. If you're supported by the place that hired you. And my clinical interest has actually been in breast cancer radiation, because radiation actually really affects reconstructive outcomes. And so one of the studies that we looked at was patients undergoing breast reconstruction with implants following radiation, and really the time for which you're able to exchange an implant. And this is really a lot of minutia and a lot of extra detail. But the long story short is I wanted to kind of crack the code of radiation to see, how can we better reconstruct the breast cancer patient in the setting of radiation? And also, there's different ways that we can reconstruct breast cancer patients. But what is the most effective way in the setting of post-mastectomy radiation that we can really help them? And this was another study that we're completing that looks at rate of major complications following radiation and risk factors for complications, to kind of better understand how we can treat patients who have a history of radiation. And this is a third study that we're interested in, which looks at mastectomy and different types of reconstruction you can either do using your own body tissue, or you can use expander or implant-based reconstruction. But which one is better? How can we better provide care to the patients who are getting radiation following breast cancer, so that they don't have a higher rate of complications than the average patient? And these are some of the other studies that we're doing specific to breast reconstruction and radiation that are currently underway. So I wanted to take the time. I think the most important thing about these talks is giving advice to those who are listening. And this is an international community, so I wanted to give a few words of advice for international students. We wrote this book chapter on international medical graduates in the United States. I encourage you all to read it if you would like. I get nothing out of you reading it, but I think that we try to provide a comprehensive review to international medical graduates in the United States, especially for those who are interested in more competitive fields like plastic surgery, dermatology, radiation oncology. And even though I was born in Lebanon and did my training in the United States, obviously I consider myself international just by the virtue of having so many international friends. And I really know how hard it is to make it in the United States when you come from a foreign background. But so there is a lot of useful insight into this in this chapter. This is one of the figures from our chapter that looks at various disciplines, and you can see plastic surgery in the middle. You can see vascular surgery, and what the green in this figure shows how common programs are willing to accept international medical graduate. So internal medicine, you can see it's very high, and that's why a lot of programs in internal medicine have a lot of foreign medical graduates, but things like plastic surgery are very, very low. But that doesn't mean that your dreams are shot and that you can't do it. And I'm happy to mentor you, and I have some useful advice that I'll share in a little bit. But it's just something to be aware of. It's very difficult, particularly in the United States. And this is another figure that we included in our chapter that basically gives kind of an outline of steps for what you can do to have a successful match in a specialty of your choice for an international medical graduate. And you can first secure letters of recommendation, establish mentorship, establish networking, find research opportunities, and obtain honors. And so you obviously want to excel academically. I think that's most important. I think, unfortunately, we all know that when you're an international medical graduate trying to make it in a different country, you have to be the best. That's basically what it comes down to. Some of it is luck, but a lot of it is working hard and working hard to be the best. You want to have some research experience in the country of your choice. So if you want to go to the US, you have to have some research experience in the US. Obviously, you have to complete your medical training steps. And now that USMLE Step 1 is pass fail, do the best that you can do on USMLE Step 2. And one other thing that I recommend, and even I'm interested in it, is maybe an advanced degree, and doing an advanced degree in the country that you're interested in going to, like a PhD or an MPH or an MBA, will help you meet some mentors in those countries. And that will allow you to match into a specialty of your choice. But here's a summary of advice based off of my personal tips for an international graduate who's hoping to make it in a different country, or maybe you're hoping to go and train in a different country and then go back to your own country so that you can give back. And I'd love to go back to Lebanon and help as well. That's one of my future goals. But you have to do rotations abroad. So wherever you want to end up, you have to do rotations there. You have to meet people in those countries, and you have to have mentors and people who will really fight for you. It's critical. You have to do some research abroad. As I said, you have to stand out, and it's unfortunate, and this is something that I hope to do in my future, but I would love to fight for the international graduates, because frankly, I feel that they're the best. I really do. But for now, you have to really shine above the others, which means you have to do research. You have to rely on key mentors in strategic positions in geographic relations, geographic location of your choice. So let's say, you want to go to England, or you want to go to France, or you want to go to the US. You need mentors in those locations who will help you get there. And I think that that's very critical. That's why I highlighted it here. I think also you can start broad and narrow your focus after getting your foot in the door. So I think that's very important. I think that if you want to do plastic surgery, for instance, you can match into a general surgery preliminary position. You try to match into a general surgery position, categorical or preliminary. And once you get your foot in the door, that's where you can show everything that you excel at, all of your talents. And I have to say, when I was a general surgery resident at Hopkins, the preliminary residents who were from all over the place, Lebanon, Germany, Switzerland, were the best. And they did that because they were so hardworking, because they really wanted to make it. So you can start broad and then narrow your focus. Your point is that you want to get your foot in the door. It's very hard to come from an international location and just jump to dermatology, or jump to plastic surgery, or jump to radiation oncology, because there are so many people that are seeking those positions who are just in that country, that it's almost impossible to get them. It's not impossible, but it's very, very difficult. Always remember your roots. And that's why, if I have people reaching out from Beirut and overseas, or any of the Middle East, or anywhere really, I remind myself that I'm fortunate that I was born overseas, but I eventually did a lot of my education in the United States. And that has helped me. But even though it's helped me, you have to also remember all those who are struggling, who are on visa status and don't have dual citizenship and struggle. So you have to give back. And so I think that's very important. And then my mom always used to say, this is an Arabic saying, but don't throw rocks in the well that you drink from. And I think that that's very important. So if you're given the opportunity to do something very special, never talk down about the opportunities that you were given, because they helped advance you in your life, and never throw rocks in the well that you drink from. And my mom reminds me of that to this day. And I think that's very important. And then unfortunately or fortunately, you have to work harder than the rest. And when I did my sub internship at Hopkins, I literally, no joke, was 3 a.m. to probably 10 p.m. every day, just trying to prove a point that I could work harder and be better than anyone around me. And I'm fortunate to have been to a lot of these places, and none of it is thanks to me. A lot of it is thanks to my parents and God and those around me who supported me. And so I take credit for none of it, but if you work hard, some of it will come to fruition. And these are my 3 girls on the left-hand side, and this is my current boss on the right-hand side, Joseph Cerletti, who's one of the pioneers in plastic surgery. And it's really, I showed a picture of him and a picture of my girls just to show you that you have to have a good work-life balance. And my dad passed away, and at any moment life can change, and you have to really appreciate the good things in life, and regardless of what you do, you have to make time for that. But you have to have a boss and a surrounding work environment that appreciates that and will help you do it. So in summary, I hope that you all have learned something, and I'm happy to answer any questions.
Thank you, Dr. Said. We would like to take a moment to express our heartfelt gratitude for the time and effort you've devoted in sharing your expertise with us today. Your presentation has been of valuable contribution towards understanding how your journey through medicine has been both challenging and rewarding. Your passion for your work reflected through everything that you spoke today, and was very evident that your dedication to medicine goes far beyond the operating room. We're honored to have had the opportunity to learn from your extensive experience and knowledge. That being said, we will be taking a couple of questions from the audience now. There were questions that were sent through the chat, both through the website and through every other platform. And let me just read a couple of the questions that we've got from the audience today. The first question is, you mentioned that you came from a very small medical school. What were the biggest factors in helping to get accepted in one of the biggest medical schools? Was it your elective, good marks, research, or a mix of everything? How does each one of these matter?
Yeah, that's a great question. I think that you, number one, have to actually show the big medical school. You have to prove yourself, and the only way to prove yourself is to really spend some time at that medical school within people that are important. And so I'm going to be very, very honest with you. And even though I love research now, at the time when I was applying to Hopkins, I had 1 publication in process. So it was now, and now I have 100, but at the time I had no interest in research, and I had very little research, but I was willing to learn, and I was willing to do it in the future. And now I've absolutely fallen in love with it. So research was not my strong suit. I came from a small medical school, but what was my strong suit was that I was a very hard worker. I'd like to consider myself humble and self-deprecating. And so I never talk highly about myself. And people want to train somebody who is enjoyable to be around, who will boost up their colleagues more than they boost themselves, who will never put work on other people. And as you guys know, you have a wonderful journal, and you guys all probably help each other out, but you all know and have been in a position where other people are throwing work on you and trying to get out of work, but you want to be the person who really takes work from others and helps create a very positive environment. And the only way to show any of that is to spend some time at that institution. And so I went for a month. I worked the hardest that I've ever worked in my life. Honestly, to this day, I worked the hardest. I was so tired, I was falling asleep in the operating room standing up. And, I was as nice as I could possibly be, as receptive to feedback. try to meet as many people as possible, and believe in your dreams. Don't let anyone tell you that you can't do what you want to do. I remember as a medical student, somebody was talking about head and neck surgery, and they were saying you have to be number one in your class to do head and neck surgery. You have to have the best scores. You have to do this. You have to do that. And really, that's not true at all. You just have to want to do it and work hard, and you will do it. So.
Thank you very much. We have a second question. I think it's very interesting, and I see that this question is one of the components of the pictures that you showed us from your book. This question goes: what advice do you have for international medical students who are searching for competitive electives in the United States?
Yeah, that's a very good question, and I think that there are some resources that you can look online. And honestly, what I've had some international people do is, and what I would recommend is, for a country of your choice, like let's just use the United States as an example, because people may want to go somewhere else, like England or France or wherever. Let's use the United States as an example. Within the United States, you have to think, where do you want to go geographically? Or you're just open to whatever geographically. And you have to think about the specialty of your interests. What do you want to do? Dermatology? Do you want to do plastic surgery? Do you want to do medicine? And then go to those medical center websites and find a few key contacts. And one thing that I would recommend, and I honestly used to do this because as people know, Lebanese people look out for other Lebanese people. And so I used to, even from a small medical school, I used to go to other institutions and look for people who I would think were from Lebanon. And I would email them. And there's a few, there's a guy, Sherbil, in Chicago, who I emailed. There's a guy who's the program director of plastic surgery at NYU, Pierre Saadeh, who is Lebanese, Samir Mardini. And that's one way you can do it, is you can find people that share your national heritage and they want to give back. And that would probably be my biggest recommendation. So you go to those people, you find their email addresses, and you connect with them. And most oftentimes you'll find is that they want to help you, and they can kind of guide you in the right direction. I will have to say, though, that visa status is very, very hard. And a lot of institutions, the moment they see that you're on visa status, they'll say, this is too much of a headache for us to deal with. And so you want to kind of have a game plan for what you can do to rest their anxiety. And that's a whole other conversation in itself.
Thank you very much. Before moving on, just on the side note, please note that we have a feedback form that has been posted in the chat section already for you guys to be able to secure your certificates. And to be respectful of everyone's time, we will be discussing one last question. The last question that we have here is, as a medical student, how do you believe research will affect our pathway? Is it more about quantity of research we publish or the quality of the papers that we publish?
Very, very good question. I think that first off, do whatever we all do what we sometimes do what we don't enjoy just because we know that we have to do it in order to get us to a certain location. But try to find a way that what you're doing is what you enjoy. And, I had one boss tell me that if you love what you do, you'll never work a day in your life. So rather than think so much about quantity and quality, say to yourself, how can I make it so that I enjoy what I'm doing, or I enjoy the research that I'm doing? And even if that ends up being 3 publications or 1 publication, if you really come across as somebody who really enjoys what they did, you came up with a research question, you did it, and that really resonates with the person who you're trying to work with, I think that's most important. I don't care if somebody comes to me with 100 publications and clearly they just did it because, obviously it shows that they work hard. But if I ask them questions about their research and they can't answer it, or they have no passion for what they're doing, that's less important. So I think it's a combination. I think most importantly, you can always, regardless of what you want to do, you can always find something that brings you joy. And try to do that with your research. Try to really enjoy it. So if somebody asks you about it, you can really show that you're passionate about it. And you definitely, like I said, coming from overseas, you have to have quantity and quality, unfortunately. So.
Thank you very much, Dr. Said.
Of course.
So I'm certain that the audience have found this presentation both informative and engaging, and the valuable insights that you shared today will resonate with us long after the event is ended. Once again, we extend our sincerest thanks to our dear speaker for his valuable contribution to the webinar and to everyone in the audience that joined us today. We had over 200 participants across all platforms, including the website and YouTube. Thank you all for taking out this time so we can be synonymously present here. I hope you leave this webinar full of inspiration and new morale. See you next time with yet another Future Leaders in Medicine webinar. Thank you very much.
Thanks so much, everybody.